Bacterial sepsis following pregnancy. Green Top Guideline number 64B, April 2012. Background and introduction. Sepsis may be defined as infection plus systemic manifestations of infection. Severe sepsis may be defined as sepsis plus sepsis-induced organ dysfunction or tissue hypoperfusion. Septic shock is defined as the persistence of hypoperfusion despite adequate fluid replacement therapy. Sepsis in the puerperium remains an important cause of maternal death, accounting for around 10 deaths per year in the UK. Severe sepsis with acute organ dysfunction has a mortality rate of 20 to 40%, rising to around 60% if septicemic shock develops. Table number 1. Risk factors for maternal sepsis as identified by the confidential inquiries into maternal deaths. Obesity, impaired glucose tolerance, or diabetes, impaired immunity or immunosuppressant medication, anemia, vaginal discharge, history of pelvic infection, amniocentesis and other invasive procedures, cervical cerclage, prolonged spontaneous rupture of membranes, vaginal trauma, cesarean section, wound hematoma, retained products of conception, Group A streptococcal infection in close contacts or family members, and Black or minority ethnic group origin. What are the common organisms causing sepsis in the puerperium, including hospital-acquired infection? The major pathogens causing sepsis in the puerperium are Group A Streptococcus, also known as Streptococcus pyogenes, Escherichia coli, Staphylococcus aureus, Streptococcus pneumoniae, and methicillin-resistant Staphylococcus aureus or MRSA, Clostridium septicum, and Morganella morgani. Group A Streptococcus is increasingly causing invasive infections worldwide and was directly responsible for 13 of the 29 maternal deaths from infection in the UK during 2006 to 2008. Gram-negative bacteria that produce extended-spectrum beta-lactamases, or ESBL, are an increasingly common cause of co-amoxiclav and cephalosporin-resistant urinary tract infections. Management. What are the likely causes of sepsis outside the genital tract, and how might they be identified? A general history and examination should be carried out to try and identify the source of sepsis. Women should be assessed clinically, and if unwell or with dehydration or vomiting, admission should be considered. Mastitis, urinary tract infection, pneumonia, Skin and soft tissue infection, gastroenteritis, and pharyngitis are likely causes of sepsis other than the genital tract. Rare causes include bacterial meningitis. Mastitis. Mastitis is easily overlooked clinically but may lead to breast abscesses, necrotizing fasciitis, and toxic shock syndrome. Immediate referral to hospital is indicated if the woman with mastitis is clinically unwell, if there is no response to oral antibiotics within 48 hours, if mastitis recurs, or if there are very severe or unusual symptoms. Urinary tract infection. Gram-negative bacterial infections are particularly associated with the urinary tract. Acute pyelonephritis should be treated aggressively. Although not all women may warrant hospital admission, those with signs of sepsis, those who are unable to remain hydrated, and those who are vomiting should be admitted. Identification of urinary sepsis is primarily clinical, but the presence of leukocytes, protein, and blood in a midstream specimen of urine may be suggestive of current infection, and a specimen should be sent for culture. Pneumonia. Hemoptysis may be a feature of pneumococcal pneumonia. Severe hemoptysis and low peripheral white cell count suggest PVL or Panton-Valentine leukocidin-associated staphylococcal necrotizing pneumonia, which has a mortality rate of more than 70% in young, fit people. Identification of the cause of pneumonia is by submitting a sample of sputum to the laboratory for culture. Skin and soft tissue infection. Any woman with suspected bacterial sepsis should be carefully examined for skin and soft tissue infection, particularly looking at intravenous cannula or injection sites and cesarean or episiotomy wounds. Swabs should be taken of any discharge. If drains, vascular access devices, or other indwelling devices are suspected as the source of infection, they should be removed as soon as is practicable. Skin and soft tissue infections are particularly associated with toxic shock syndromes. Recurrent abscess formation, including labial abscesses, is a feature of PVL-producing staphylococci. Septicemic seeding of streptococci from a uterine focus may give rise to a secondary focus in the limb, simulating a venous thrombosis. Early necrotizing fasciitis occurs deep in the tissues. Therefore, in early necrotizing fasciitis, there may be no visible skin changes. As the necrotizing process ascends to the skin, late infection produces blisters and obvious necrosis. The cardinal feature of necrotizing fasciitis is of agonizing pain, typically necessitating increasing amounts of strong analgesia, culminating in use of opiates. Women with suspected thrombosis who are systematically unwell with any features of sepsis should be examined very carefully. Gastroenteritis. Salmonella and Campylobacter rarely cause severe systemic infection and should be managed symptomatically unless features of bacteremia are present. Diarrhea and vomiting may be features of toxic shock syndrome together with features of profound sepsis. Clostridium difficile is rare but increasingly found in obstetric patients. Pharyngitis. Most cases of pharyngitis are viral, but approximately 10% of cases in adults are attributable to group A Streptococcus. If 3 of the 4 CENTOR criteria, fever, tonsillar exudate, no cough, and tender anterior cervical lymphadenopathy are present, treatment with an antibiotic is appropriate. Infection related to regional anesthesia. Spinal abscess is a very rare complication after regional anesthesia in obstetric patients. The usual organism responsible is Staphylococcus aureus with streptococci, gram-negative rods, and sterile specimens accounting for 15% each. What should prompt recognition of sepsis in the puerperium? All health professionals should be aware of the symptoms and signs of maternal sepsis and critical illness and of the rapid, potentially lethal course of severe sepsis and septic shock. Suspicion of significant sepsis should trigger urgent referral to secondary care. Sepsis should be considered in all recently delivered women who feel unwell and have pyrexia or hypothermia. The common symptoms of sepsis in the puerperium include fever, diarrhea, vomiting, abdominal pain, generalized maculopapular rash, staphylococcal or streptococcal sepsis, offensive vaginal discharge, and signs of infection in cesarean wounds. Clinical signs suggestive of sepsis include one or more of the following: pyrexia, hypothermia, tachycardia, tachypnea, hypoxia, hypotension, oliguria, impaired consciousness, and failure to respond to treatment. These signs, including pyrexia, may not always be present and are not necessarily related to the severity of sepsis. Conjunctival suffusion is a classic sign of toxic shock syndrome. Agonizing pain out of proportion to the clinical signs suggests a deep infection, and necrotizing fasciitis or myositis must be considered. Mastitis must never be overlooked. Abdominal pain, fever greater than 38 degrees Celsius, and tachycardia greater than 90 beats per minute in the puerperium are indications for intravenous antibiotics and senior clinical review. Non-steroidal anti-inflammatory drugs or NSAIDs should be avoided for pain relief in cases of sepsis as they impede the ability of polymorphs to fight group A streptococcal infection. Since non-steroidal anti-inflammatory drugs or NSAIDs significantly impede the ability of polymorphs to fight infection caused by group A Streptococcus, they should be avoided for pain relief in cases of sepsis. Table number 2. Common symptoms of sepsis in the puerperium. Fever, rigors, persistent spiking temperature suggests abscess. Beware, normal temperature may be attributable to antipyretics or non-steroidal anti-inflammatory drugs or NSAIDs. Diarrhea or vomiting may indicate exotoxin production or early toxic shock. Breast engorgement or redness, rash, generalized maculopapular rash, abdominal or pelvic pain and tenderness, wound infection, spreading cellulitis or discharge, offensive vaginal discharge, smelly, suggestive of anaerobes, and serosanguinous, suggestive of streptococcal infection. Productive cough, urinary symptoms, delay in uterine involution, heavy lochia, general non-specific signs such as lethargy and reduced appetite. Some cases of sepsis in the puerperium may present initially only with severe abdominal pain in the absence of fever and tachycardia. Any widespread rash should suggest early toxic shock syndrome, especially if conjunctival hyperemia or suffusion is present. A generalized macular rash is present in most cases of staphylococcal toxic shock syndrome, but in only 10% of cases of streptococcal toxic shock syndrome. What are the appropriate triggers or features of sepsis in the puerperium that should prompt hospital admission? Community carers should be aware of the importance of early referral to hospital of recently delivered women who feel unwell and have pyrexia, and should be aware of the possibility of sepsis in the puerperium. If sepsis is suspected in the community, urgent referral to hospital is indicated. Red flag signs and symptoms should prompt urgent referral for hospital assessment, and if the woman appears seriously unwell, by emergency ambulance. Pyrexia more than 38 degrees Celsius, sustained tachycardia more than 90 beats per minute, breathlessness, a respiratory rate of more than 20 breaths per minute is a serious symptom. Abdominal or chest pain, diarrhea and or vomiting, uterine or renal angle pain and tenderness, and woman is generally unwell or seems unduly anxious or distressed. Early presentation of sepsis, less than 12 hours post-birth, is more likely to be caused by streptococcal infection, particularly group A Streptococcus, and severe continuous pain suggests necrotizing fasciitis. Infection must also be suspected and actively ruled out when a recently delivered woman has persistent vaginal bleeding and abdominal pain. If there is any concern, the woman must be referred back to the maternity unit as soon as possible. What are the indications for admission to the intensive care unit? The presence of shock or other organ dysfunction in the woman is an indication for admission to the intensive care unit or ICU. Table number 5. Indications for admission of the woman to the ICU as adopted from Platt and Ray of 2008. System: cardiovascular. Indication: hypotension or raised serum lactate persisting despite fluid resuscitation, suggesting the need for inotrope support. Respiratory, pulmonary edema, mechanical ventilation, and airway protection. Renal dialysis. Neurological, significantly decreased conscious level. Miscellaneous, multi-organ failure, uncorrected acidosis, and hypothermia. What is the optimum way to monitor women with suspected sepsis in the puerperium? Monitoring of the women with suspected severe sepsis or established sepsis should be multidisciplinary, but preferably under the leadership of a single consultant. A senior obstetrician should be involved in consultation with an intensivist, microbiologist, or infectious disease clinician. Regular observations of all vital signs, including temperature, pulse rate, blood pressure, and respiratory rate, should be recorded on a modified Early Obstetric Warning Score or MEOWS chart. What infectious disease history or information should be noted? Any recent illness or exposure to illness in close contacts, particularly streptococcal infections, should be noted. A history of recent sore throat or prolonged household contact with family members with known streptococcal infections, pharyngitis, impetigo, and cellulitis has been implicated in cases of Group A streptococcal sepsis. Intravenous drug misuse carries a higher risk of staphylococcal and streptococcal sepsis, as well as generalized immunosuppression of chronic disease, endocarditis, and blood-borne viruses. Recent febrile illnesses, especially if associated with chills and rigors, suggest bacteremia. Gastrointestinal symptoms such as diarrhea and vomiting may be attributable to foodborne pathogens, Clostridium difficile infection, or early toxic shock. Ingestion of unpasteurized milk products raises the possibility of infection with Salmonella, Campylobacter, or Listeria. Chlamydophila psittaci is acquired by contact with aborting sheep or infected birds, or by cross-infection from washing contaminated clothing. Q fever is caused by Coxiella burnetii after inhalation of infectious particles from birthing animals or contaminated dust. What investigations should be performed? Blood cultures are the key investigation and should be obtained prior to antibiotic administration. However, antibiotic treatment should be started without waiting for microbiology results. Routine blood tests should include full blood count, urea, electrolytes, and C-reactive protein or CRP. Serum lactate should be measured within 6 hours of the suspicion of severe sepsis to guide management. Serum lactate greater than or equal to 4 millimoles per liter is indicative of tissue hypoperfusion. Blood cultures and other samples taken should be guided by clinical suspicion of focus of infection, such as throat swabs, midstream urine, high vaginal swab, throat swab, placental swabs, sputum, cerebrospinal fluid, epidural site swab, cesarean section or episiotomy site wound swabs, and express breast milk, and should ideally be obtained prior to starting antibiotic therapy, as the results may become uninformative within a few hours of commencing antibiotics. If diarrhea is particularly offensive following antimicrobial therapy, a stool sample should be submitted for Clostridium difficile toxin testing. A history of diarrhea warrants routine culture, for example, Salmonella and Campylobacter. Any relevant imaging studies should be performed promptly in an attempt to confirm the source of infection. This could include a chest X-ray, pelvic ultrasound scan, or computed tomography scan if pelvic abscess is suspected. If the methicillin-resistant Staphylococcus aureus status of the woman is unknown, a pre-moistened nose swab may be sent for rapid MRSA screening where such testing is available. Any women with symptoms of tonsillitis or pharyngitis should have a throat swab sent for culture. Appendix number 2. Diagnostic criteria for sepsis modified from Levy et al. Using Center for Maternal and Child Inquiries and Lewis were pregnancy-specific parameters available. How should sepsis in the puerperium be managed? The focus of infection should be sought and dealt with. This may be by uterine evacuation or by drainage of a breast, wound, or pelvic abscess. Broad-spectrum antibiotics should be given to cover these procedures. Which antibiotics should be used? Administration of intravenous broad-spectrum antibiotics within 1 hour of suspicion of severe sepsis, with or without septic shock, is recommended as part of the surviving sepsis resuscitation care bundle. If genital tract sepsis is suspected, prompt early treatment with a combination of high-dose broad-spectrum intravenous antibiotics may be life-saving. A combination of either piperacillin and tazobactam or a carbapenem plus clindamycin provides one of the broadest ranges of treatment for severe sepsis. Methicillin-resistant Staphylococcus aureus may be resistant to clindamycin. Hence, if the woman is highly likely to be MRSA positive, a glycopeptide such as vancomycin or teicoplanin may be added until sensitivity is known. Breastfeeding limits the use of some antimicrobials, hence the advice of a consultant microbiologist should be sought at an early stage. What are some of the adverse effects of treatment? Treatment with any antimicrobial can cause allergic reactions, including skin rashes. However, it should be remembered that, particularly in toxic shock, a maculopapular or blanching erythema may be exotoxin related and not an allergy to the therapy. Diarrhea, particularly if offensive or developing after any antimicrobial therapy, should be sent for Clostridium difficile toxin testing. The organism does not infect neonates but can cause up to 30% mortality in mothers if untreated. What is the role of intravenous immunoglobulin or IVIG? Intravenous immunoglobulin is recommended for severe invasive streptococcal or staphylococcal infection if other therapies have failed. Intravenous immunoglobulin has an immunodulatory effect, and in staphylococcal and streptococcal sepsis also neutralizes the super antigen effect of exotoxins and inhibits production of tumor necrosis factor and interleukins. The main contraindication to intravenous immunoglobulin use is a congenital deficiency of immunoglobulin A. Where should women with sepsis be cared for? Women with sepsis in the puerperium are best managed in a hospital where diagnostic services are easy to access and intensive care facilities are readily available. Early referral to hospital may be life-saving. How should a drug misusing woman be managed? Women with a history of substance misuse are usually monitored under multi-agency care. The local drugs advisory specialist team and existing hospital guidelines for care of substance misusers or drug users should be consulted. Any injection site lesions should be swabbed and an MRSA screen performed. Alternative access devices, such as a central venous catheter or peripherally inserted central catheter, are more likely to be required for long-term intravenous antibiotic treatment, and early referral of the woman to a vascular access team or equivalent is desirable. What are the infection control issues? The women should be isolated in a single room with an en-suite facilities to reduce the risk of transmission of infection. Mothers or neonates infected or colonized with high-risk organisms such as Group A Streptococcus, methicillin-resistant Staphylococcus aureus, or Panton Valentin leucocidine producing staphylococci may generate outbreaks within the healthcare setting, especially for other babies in nursery units and staff. The local infection control team should be informed of any such cases and appropriate isolation precautions followed. Healthcare workers, defined as doctors, midwives, nurses, anesthetists, and members of the wound care team, should wear personal protective equipment, including disposable gloves and aprons, when in contact with the women, equipment, and their immediate surroundings. Isolation in a single room within en-suite facilities is recommended since numerous streptococcal outbreaks have occurred in maternity units, some involving shared toilet and shower facilities. Methicillin-resistant Staphylococcus aureus and Group A Streptococcus are easily transmitted via the hands of healthcare workers and via close contact in households. Local infection control guidelines should be followed for hospital-specific isolation and contact precautions. PVL-associated infections should be managed in accordance with national guidelines. Breaks in the skin of the woman or carer must be covered with a waterproof dressing. Fluid-repellent surgical masks with visors must be used at operative debridement, change of dressings of Group A Streptococcus necrotizing fasciitis, and for other procedures where droplet spread is possible. Visitors should be offered suitable information and relevant personal protective equipment while the woman is isolated. What are the neonatal issues if sepsis develops in the puerperium? The baby is especially at risk of streptococcal and staphylococcal infection during birth and during breastfeeding. The umbilical area should be examined and a pediatrician consulted in the event of sepsis in the puerperium. If either the mother or the baby is infected with invasive Group A Streptococcus in the postpartum period, both should be treated with antibiotics. What are the indications for prophylaxis to family and staff? Close household contacts should be warned about the symptoms of Group A Streptococcus infection and told to seek medical attention should symptoms develop. Asymptomatic contacts may warrant prophylaxis. Local and national guidelines should be followed in consultation with the local health protection unit or consultant for communicable disease control. Can sepsis in the puerperium be prevented or detected earlier? All pregnant and recently delivered women should be informed of the signs and symptoms of genital tract infection and how to prevent its transmission. This includes avoiding contamination of the perineum by washing hands before and after using the lavatory or changing sanitary towels. It is especially necessary when the woman or her family or close contacts have a sore throat or upper respiratory tract infection. Any group A streptococcus identified during pregnancy should be treated aggressively. All clinical staff must undertake regular, written, documented, and audited training for the identification and initial management of serious obstetric conditions or emerging potential emergencies such as sepsis, which need to be distinguished from commonplace symptoms in pregnancy. Any signs of infection or necessity to administer antibiotics noted during a woman's hospital stay should be reported directly to her community carers, which involve a general practitioner, midwives, and health visitors when she is discharged so that appropriate follow-up visits may be arranged and the significance of developing symptoms recognized. Appendix number 1. Staphylococcal and streptococcal toxic shock syndrome, clinical disease definition.